the webinar series, but basically trying to tell clinicians what sort of information it's really helpful to have knowledge of prior to speaking to biostatisticians about the design of clinical trials. However, the goal of this talk is sort of the converse of that to a certain extent, because even though a lot of people went to that webinar, in the world of clinicians, most people didn't hear her talk, and they may not come with actually the information that you would hope that they have. And the goal here is for me to potentially give some perspectives on things that it would be good to try to elicit from the clinicians or suggest that they bring to the table from the perspective of study design to make these conversations more productive. Now, our overall course philosophy emphasizes an approach in clinical trials with biostatisticians and clinicians being equal scientific partners from the beginning in terms of the design, with the clinicians bringing expertise in the mechanism of action, the disease of interest, and the biostatisticians bringing in great expertise in the design of experiments, rigor, reproducibility. Now, that's not to say that this is actually, these are strict, this is a strict dichotomy. Many biostatisticians know a lot about the clinical disease processes that they help design trials for. And in certain disease states, in terms of, I've been relatively new to traumatic brain injury studies, at least from my perspective. I would talk to Sharon a lot about them because she knows a lot about them. Now, if somebody has bumped their head in the emergency department, I'm probably better at taking care of that patient. But as Sharon knows, there's actually no treatments that we actually do anyway. So there isn't, other than trying to keep them alive, basically. There isn't a lot. So we as a clinical community in TBI really need Sharon a lot to help us design trials that will ultimately give us treatments that will actually do something. So it's this idea of sort of, you're not going to be as expert in some of the aspects of the clinical medicine, but depending on what sort of relationship you develop with clinicians over the years, you may become quite expert in the diseases. And in certain cases, like there are biostatisticians at MD Anderson, they certainly know more about cancer than me. I mean, I'm in the emergency department, and I'm like, that person has cancer, right? Like, I need to admit them to the hospital and give them antibiotics. Like, that's, not sort of throwing emergency medicine under the bus, but that's a lot of what I do. And that biostatisticians who've thought of some of these complex designs with phenotyping, specific targeted chemotherapies to address specific phenotypes may actually have a great deal more content expertise in cancer than me. So I think when you are sort of getting started, though, in a relationship, particularly, I guess, for our target audience here, you may be dealing with clinicians who have a wide variety of experience, and oftentimes you may be dealing with junior clinicians. So in this situation, you are both in a spot where the clinician may not have experience in working with biostatisticians. I even remember when I was doing a master's in biostatistics, and we had a statistical consultation service at the University of Michigan, and going there, even though I was starting to take some SAS classes, and I knew about Proc-Freq and some of those other things, it was still extremely intimidating to me because I'm like, gosh, I don't know very much, right? And it was a fine experience, and I worked with some fine people through the statistical consulting service on things like complex survey designs, and I just happened to actually, a lot of this tends to, some of it is block in terms of, this is Brady West at the University of Michigan, he was really good at actually asking the questions and eliciting the information from the sort of scared clinician who didn't know much, and getting you to move into the directions of giving the information that you need to actually come up with a reasonable approach. And while our course here, we are emphasizing the design of clinical trials and clinical experiments, across clinical research, a lot of these themes exist. So I think one of the things that's most important to try to get at first is trying to figure out what exactly the clinician is trying to do. And I think you need to walk us clinicians back from I got this thing, I know it works, and I need you to like figure out how I can sort of demonstrate this. Because the correct answer is, the correct way of phrasing that question is not, I know this thing works and I need your help to figure out how to prove it. It's like, we need to be asking a question of, does this work, and in who does it work, and where are things going next, right? Like, what we're doing that, like the video you show, it's like, how many patients do I need for this study? We always use 3 patients, right? Like, we always use 3 patients, and that the sort of derivative of that is for like phase 3 stroke trials. We always use 1,400 patients, like, we always use 1,400 patients, but that's a discussion for another day. So you have to get people to what is it that they're trying to do, and also have them talk a bit about the disease. But you have to focus this conversation, because sometimes us clinicians, we get very excited about things, because you're like, what is the patient-oriented outcome that ultimately matters? And if they're doing an early phase study, is there some reasonable surrogate? And in neurology, most of the time, there isn't, and that's one of the things why a lot of what we talked about yesterday, futility designs are quite popular, is because you're actually using that reference disability outcome that you would be using in phase 3 in some of the early phase trials. But there are other important questions that need to be answered earlier, such as target engagement and other things like that. Now, one of the things, though, that I think is most important is getting some sense of what it is that's going on with the disease. And this article here from Dr. Elm and others is, I look at this article, and I'm not going to read this article to you, and Parkinson's disease will also fall into a category of diseases, since I'm focused on neurologic emergencies, and also my clinical practice is mostly in emergency medicine and stroke. I basically know what I know about Parkinson's disease from what I learned in medical school, and for my emergency medicine practice is, it's sort of like, oh God, this person has Parkinson's disease, and they've been stuck in my emergency department 10 hours, and now they're kind of completely not doing anything. They need their Cinemat. And that's what I know about it. So I can say definitely, Jordan knows a lot more about this disease. But in terms of, if you look at this article is great in terms of looking at and like where you got to, like the information that went into this article in terms of deciding how this outcome measure should be used is like the gold standard of if you can elicit all of this information from a clinician, and obviously this was within the scope of a large network that was doing Parkinson's trials. But one of the things that in this chronic disease, you have to learn, well, what's going on with Parkinson's? What's the problem with it? And that people are having problems with tremor, and they're having decreased capacity to do things with their motor skills. And then, so that like, well, what do you usually use? And one question you can ask, if people are like, I don't know what outcome to use, say, well, okay, if there was a New England Journal of Medicine article showing that some new treatment that's transformed the field in this disease was published or has been published before, what was the primary outcome measure in that study? And usually, if you answer that question that specifically, they may not know off the top of their head, or they might, and they may be able to say, oh, well, for Parkinson's, that was the UPDRS. And we say, okay, so, tell me more about the UPDRS. And again, it's this idea of like, well, there's this motor scale that deals with how much they can do motor things that involve the muscles. And then there's also this activities of daily living scale. But again, you as statisticians say, well, what are activities of daily living? Can you dress yourself? Can you bathe yourself, et cetera? Those are things you know. But then then you're still automatically thinking in the back of your head, although we may not think this way as clinicians. It's like, oh, there's going to be a fair bit of correlation between those two things, because if you have a lot of tremor, it's going to diminish your activities of daily living. But then there's also the mentation scale, which may not actually track with those other things. And in this study where they looked at a lot of the data from prior placebo studies, what they were really looking at was how should we use these outcome measures to design future early phase trials in Parkinson's. And so once you get the sense of this is your outcome measure, then you want to try to elicit from them, like, what are the dynamics of this outcome measure? Like, what happens with it? Where does it go? How does it behave? And one of the things that I think it was Jeremy was talking about yesterday is that while some of these things might look like they're kinda normally distributed? They're not. This is an ordinal scale, but it's a non-interval scale. And in where I work, we have like one of the gnarliest things that, scale, the NIH stroke scale is sort of the worst in that, like, it's very non-interval in that there's, each point is not meaning the same thing. It's all over the place, but it's often used as an interval scale, and that's one of the things. Now, there are so many things that you can try to stamp out in terms of bad things us clinicians do, because we have access to SAS on our computers, and we're going to just use proc logistic, and we're going to put NIH stroke scale as a continuous predictor into a lot of our models. And we're not going to stop all of that here today. We can all sort of chuckle about it, but the idea here is when you're at this like new clinician, new disease, like, what is going on with this, and getting a sense of what are the dynamics of this. If this is a chronic disease, most of the time chronic diseases get worse, and the biggest thing we want to try to do in those chronic diseases is alter the trajectory of that disease, and getting a sense as to what, again, sort of second nature to someone who's trained as a statistician. You need to know what is the expected trajectory in that outcome measure and what is the variability in that outcome measure. And getting that out of the clinicians, sometimes they'll be able to find good data on this. And this is something that was happening in our small groups. It's we were asking, particularly for one of our trainees who has this neurocognitive battery and is also looking at hippocampal volume loss. It's like, well, what's going on with that? How much variability is there in the 12-month outcomes? Because then you want to, we want to be able to get you the information you need, because you're sort of thinking in your head is, if this is really variable across patients and even within patients, it's going to take a much larger sample size to distinguish that signal that's coming from the new treatment from the noise of just the natural variability. So in the Parkinson's disease studies, one of the things that's quite interesting is that this is a major stratification point in this study. Like when I talk about when I have patients in the emergency department, all I know about Parkinson's is if they haven't had their Cinemet and they've been sitting for 10 hours, they're clearly stiff and they don't look very good. I mean, this is a really bad oversimplification. I didn't do a neurology residency, and when I was a medical student at the University of Cincinnati, it was like May of my senior year of medical school. I kind of skipped my neurology. I picked up. I've kind of picked it up mostly since then. P equals MD.
Come redo the rotation with us if you want.
I could come back as remedial. That'd be fun. Sounds like a little sabbatical. But one of the things that is very important now, if you're designing a trial, and this is not something that necessarily the clinician is going to become forthcoming from, but if you see up here, if people are on dopaminergic therapy, nothing is changing. So that's a major study design issue, right? So that if you're hoping for change within 12 months on the UPDRS, and they're taking dopaminergic therapy, and make sure I'm getting this right. Yeah. So this is a huge stratification point. So you're like, oh, I want to study people with dopaminergic therapy and without. And you say, if they design their trial that way, it's not going to work, because they're going to get no information from these people, because the expected variability to change is basically, sort of nothing. So now again, like I said, this is sort of a gold standard for, look at all this great information they got about the clinical disease, how they quantified it. Obviously there's a ton of variability here from some of these prior studies, but it really leads to some very meaningful recommendations as to how futility designs should be designed, what outcome measures in parts of the UPDRS are most likely to be responsive, and basically, again, this isn't going to be necessarily how every conversation you have with clinicians go when they're coming to you with a new neurological disease or non-neurological disease, but getting to this idea. Now, on the other side of the coin, obviously what I do mostly clinically are sort of sudden unpredictable diseases, cardiac arrest, TBI, stroke, and those have their own unique challenges in terms of the outcome measures, which often deal with, sometimes it's mortality, but a lot of times it's neurologically intact functioning after their event, and our treatments are meant to be restorative to help the patients recover from their very disabled state. But some things are some things that are perhaps not intuitive is that when patients are hospitalized, if in stroke studies we're typically, when we saw this yesterday, typically using this thing called the modified Rankin scale, this ordinal non-interval levels of disability going from 0 to 6, and 6 being dead, and 5 being kind of vegetative in a really not very good state. One of the issues with that scale is that sometimes it's applied when people are actually like discharged from the hospital, which it's hard to know what they're going to actually be able to, can you go back to work? I was like, I just got out of the hospital yesterday, right? Of course I can't go back to work. I had my hip replaced in January, or December 30th. I did not, if you were going to apply a modified Rankin scale to me, at hospital discharge, and I was only there like 24 hours, I mean, they were really good about getting you out, I could not return to work that day. I mean, I could have tried. If the residents were doing a lot of the work, my brain was mostly working, but it wouldn't have worked. So that in stroke studies and TBI studies, there's going to be this period potentially after hospitalization where patients are in rehabilitation, where things you can't use that disability scale sort of overlaid with this acute hospitalization. Again, sometimes people try, but it's sort of, if somebody is walking out of the hospital and is going back, they're basically, I mean, sometimes you have people in the emergency department who do so well with a drug like TPA, you give them TPA, they get better, and they're like, can I go home now? And we're like, no, we gotta like watch you a little longer and try to figure out what actually caused your stroke. So there are some spaces where that might work, but in that middle zone, is this person gonna have some degree of disability, no degree of disability? It's just a bad time point to be measuring that, which is why we mostly measure at 90 days. So getting some understanding of what is going to go on with the natural history of that disease in relation to the primary endpoint. So I think a lot of this stems from getting to know about how that endpoint they're using behaves, getting them to get you the endpoint, and also thinking about what it is they're trying to establish in their early phase trial. They're probably, as we heard from Jordan, going to come in saying, well, I want to do this early phase pilot trial, so I want you to help me prove that this drug is safe with 10 patients. And as we know that's, we're going to be able to maybe show that it's not horribly dangerous, but proving that it's safe is not something that is doable, and Chris Coffey mentioned that too. So I think with that, brief soliloquy. Let me just say, are there any other questions or follow-ups on that?
I would just comment that although the MRS at 7 days or discharge, whatever you mentioned, may not make sense, we often do collect it. So you still have to know that it doesn't necessarily make sense to use it as.
There are aspects of it, but there are aspects of it that potentially could be informative. For example, if they're dead, they stay dead. And if they're at 0, a lot of times they're going to actually do, although that's closely correlated with destination from home. So it can be a proxy for that. The middle ranges, there can be a lot of shifts over that time. But if you're doing a study and somebody gets lost to follow-up, if you knew it would help an imputation model later if you have that information, knowing that there's a zone where you're not going to have much resolution, but at the bounds of the modified Rankin of 5, 6, those people are probably going to still be doing pretty bad. There's some 5s that may move up, but there's certainly no 6s that are going to move up. So that it can provide information, and it's not necessarily useful in and of itself, even though we collect it. It's potentially useful in terms of getting early signals and perhaps being able to use it in the event that you miss a 90-day outcome. But yeah, no, we collect it all the time. I mean, there's certain studies where, there's certain cardiac arrest studies that have used it as a primary endpoint, but that doesn't mean it's okay. All right, any other thoughts or reflections on?
I think one other outcome that people struggle with sample size is anything that's like a change score. Like I know like in spinal cord injury with the Asia motor score and stuff, I think getting that information to plan sample size, that's a struggle, I think. Don't you agree? Mm-hmm.
Yeah,
talk about it?
I think the Asia motor scale
Or
is,
just any change score, any other, anything that you want to make is a change score. And I think talking with the clinicians, sometimes I don't think, not every clinician knows that's an option. So here they are thinking, I'm just going to look at the 6-month outcome or the 12-month outcome, even though they have a baseline baseline score. So having that discussion about, well, what is it you really want to know? Do you want to know the change in their functioning? Or do you want to know where they are at the end, or whatever that significant time point is?
And that's a really good example in terms of spinal cord injury, in that because in terms of knowing how that's going to behave, having prospective data that was measured in kind of the same way is essential, because if there's so much variability in this and there's so much natural recovery, you're sort of designing something in the dark, and they're like, oh, I think the standard deviation would be like something right made up, and you're like,
information,
that's not going to work, right? If we're going to be using a change score, we do have to have good prospective data. And as a neurologic researcher who's mostly done stroke, I've been banging my head against the wall about the modified Rankin and using that in early phase trials. So now it was like one of those things like, don't get mad, get even. So now I'm doing a hypertension trial, and it's like, you know really well what somebody's natural history of their systolic blood pressure is going to be, what the variability of it is. So I'm so excited to finally have a normally distributed outcome in a study that I'm doing.
We're in the shift analysis, and then
I know, right?
And then I can't even pretend to like figure anything out without you guys.
But to think about that, if you do have somebody who's doing a hypertension study, this is one of those things where for that, it also tends to go to the clinically significant difference. We know from a lot of the drug studies that have been done for antihypertensives that these things that look like pretty ludicrously low numbers, like I'm going to reduce somebody's systolic blood pressure 2 to 3 millimeters of mercury, right? For statisticians, you're like, oh, that's like within the measurement error of the devices. Like that, is that like a real thing? But if you have tens of thousands of patients, you can overwhelm that sort of noise in the measurement error. And from what's been shown in other epidemiologic studies is you can really reduce somebody's risk of stroke, heart attack, et cetera, with that magnitude of change. Even though intuitively to us clinicians, or even we're like 2 to 3, right? Like in the emergency department, we're not, or even the stroke unit, we're not even thinking about that minimal level of increment. But if somebody is being exposed to that over time, all the ups and downs that they're having it go down 2-3 points can be extremely meaningful in terms of reducing their cardiovascular risk. So, but yeah, if it's something where you do have good characterization of what change scores look like. Whereas spinal cord injury is much more, a much smaller group and harder to measure. And in stroke studies, then there's also you could say, well, maybe change an NIH stroke scale. The NIH stroke scale is a severity measure and a measure of function. It has some correlation with your ultimate level of disability, but there are some people who have very low NIH stroke scales who are very disabled. There's some people who have higher ones that don't really have much disability at all. So it's one of those things where you have to be careful and continue to ask those questions about how these things work and how they correlate with each other.
So how do you approach that with investigators? Because I do have a lot of people that come like with change, but they don't really know the variability, like the correct variability, right, about that change. Because most people will just publish the means and standard deviations before and after. But I've also read some papers that kind of advocate for more of that ANCOVA kind of type of model as well. Mm-hmm. So how do you balance that with the clinician? Do you just kind of try to like pull from them if they're really interested in change, or if they are really just interested in, what's that conversation like with them? Because both seem valid, right? In certain situations.
Yeah, they do. And I guess when I hit them with it, when they start to talk about it, then they're like, oh, I never really thought about that. And then I said, well, what do your peers want to read in literature? Are most people looking at change scores, or are they looking just at the 12-month or the 6-month outcome and then just adjusting for it? So I think it's just the interpretation to their clinical audience.
Yeah, there are some ways you can, if you have access to the raw data, then you can graphically look at it and see whether it would be better to have a change score or have an ANCOVA or something like that. But in the absence of that, I think it is more just what the community will accept. Yeah.
But so just to make sure, because I know this also gets confusing, so whenever you have a change score, I always think you should do the analysis of covariance, right? So that you should always still include the baseline.
Still include baseline.
Yeah. That's just the more proper analysis. So the analysis is almost the same.
Yeah.
It's just the interpretation of it.
Right, because you take out the variability of the baseline score,
Right.
and you can sort of normalize the data to same level.
Yeah, but sometimes it's better not to take the subtraction off of the final value. It's just better to have it in the model. So it depends on
just how you lay it.
Right, basically you can then build subsequently contrast once you have created the model as y final equal to y initial plus whatever other variables you want.
Yeah.
But then when you give them the results, right, and it's like, okay, well, you've predicted the final, and they're like, oh, that's not really what I was, you know,
Yeah,
right? I mean, that's what you're
It's
trying.
better to have that discussion
Well,
before, you know, especially with, yeah, no.
So,
Yeah.
they just.
My
Then you say you're on
question-
your own.
You're like,
so my question is, how often do we go wrong on the estimates of variability while design? And after seeing the data, how often somebody has done that
I
study?
don't know if
where-
anyone's looked at that, like written up on
Yeah.
how wrong we were.
Right. I mean, I always feel like, it always feels like when you're looking at the results section that they went back, saw the data, redid the sample size calculation
Hopefully they didn't do that.
to fit their thought process or to fit with what's going on. It feels like it at times, you know, I don't know. I
Yeah,
might be
that's,
wrong.
hopefully they're not doing that,
Yeah.
because then that defeats the purpose.
Right.
It's hard, I mean, it's hard to do that with clinicaltrials.gov because
Right.
you've got to have everything
Everything.
that's public, which is good.
It is
Right.
good.
Thank goodness.
Yeah, I know, so that would be tough to do.
I'm more talking about sort of exploratory studies, not very necessarily clinical.
Yeah.
science.
But even exploratories now, I mean, if it's a clinical trial, even in the early phases, you know, should be registered.
Should be.
But an exploratory analysis for that is.
Right.
And that's sample size.
Yeah. But, so from my personal experience, particularly when you're dealing with proportions, our assumptions are always off. But I build in, at least for the pivotal studies now, I pretty much build in a sample size re-estimation plan. Because or at least my studies are usually wrong. I don't want to speak for
Blinded.
everybody.
Well,
Yeah,
the-
you do blinded sample size re-estimation?
Yeah, I do blinded. I haven't done it
Take
unblinded.
Most of the time, it seems though, in the binary outcome type studies where they've misspecified the potential placebo rate, that a blinded sample size estimation should help
It could
that
help.
situation.
Mhm.
And when I think in terms of the variability in a continuously distributed outcome, I think I don't know how often the variability assumptions were correct, but as Valerie's pointing out, on the binary outcome ones, it's always wrong. and then the variability is tied up in where you are on the probability scale, of course.
So if you're lucky, you started out in the middle.
Right,
So
if
if
you're
you're wrong,
lucky.
it doesn't matter.
Right. So if you start in the hardest place in the middle, then you're okay. But if you're way down, which we've seen in some pediatric cardiac arrest studies, then it has a major implication if you shift towards the middle. It completely sinks your power. So that's the most common thing we see, and I think that somewhat comes to the, we always do stroke studies. There are 1,400 patients, and we always try to submit trials that are less than $100,000. Those things contribute to that behavior.
So at what stage do you recommend going those blinded re-estimation of the sample size?
I don't do them any earlier than a third of the way, usually around a third of the way. And also it depends on if I have my interim analyses, I might time the first interim analysis, kind of like a two-step approach.
Yeah, it gets a little tricky because if the sample size changes and you have an interim analysis plan, are you doing the analysis at the sample size you said you were, or are you doing it at the percentage of the newly re-estimated sample size? So you have to work out the details of that.
Well, and the interesting thing about this that we learned from doing the shadow shine is that it's really important if you're actually mixing in efficacy and futility boundaries and a blended sample size re-estimation, that there's no equation that's going to tell you how those two things are going to behave in concert, so that some simulations are helpful to learn. Because we found some weird situations, like if it's a blinded sample size re-estimation, it's based on the overall study proportion of the outcome. But you could still have great separation between the groups. So your blinded sample size re-estimation isn't looking at the difference between the groups. So there could be this huge difference between the groups, but because it's closer to the middle, the blinded sample size re-estimation is going to say, increase the study size. But then, if there is this great separation between the groups, it's going to increase the study size, and it's going to terminate the study for overwhelming efficacy at the next interim, which is kind of interesting. But it's kind of cool in that it actually, because people most of the time are like, oh, the sample size is going up, this is sort of a bad sign. But in this case, it's actually taking away information from the behavior of the blinded sample size re-estimation, because it's just going, I mean, you know that it's just going off, all the statisticians in the room know that it's just going off a blinded rate. There could still be a difference between the groups. The clinicians don't understand that at all. When they heard that their maximum sample size went up, they're thinking that the probability that their study is going to be positive went way down. But what we know from the simulations is that's not necessarily true.
Do you keep all the details for that in your, I mean, you don't go into all of that in the grants, do you? I mean, you just kind of say that you're going to do it and then leave the details for the statistical analysis plan?
I give enough details just so that obviously the peer review knows. But usually it's at the DSMB meeting, that's rare. So it's going to be in all the statistical analysis plan. But it's interesting, I guess, I've done it a few times now, and probably Jordan or Sharon can tell their experiences too. But I definitely wish that statistical analysis plan could be a confidential document completely, right? So the investigators don't see any of it because they start to react subconsciously about what they think is happening. And I'm like, I wish we could just completely separate that and keep that just between the DSMB and, I mean, they'll know the general, but then
it can create operational bias. And particularly since, one trial that we're doing has a little bit of response adaptive randomization in it. And I think you were successful in keeping that from what us investigators know in that study. I think you kept your algorithm secret.
Our random,
So,
It's like keeping your mock randomization secret, right?
It's keeping all that
and which is extremely important in SHINE, because SHINE is an unblinded study on the clinicians, and that we are either doing a tight glycemic control or not.
Right.
So if it was a placebo-controlled study, it would be less of an issue, but since it's not, even with placebo-controlled studies, it's always like, oh, the side effect profile. We're always trying to read into what the underlying machine is doing.
Right, and the randomization plan is a confidential document, and that's not in the SAP.
Yeah. Oh, you don't even keep it, because that's,
Nope.
no, okay.
Completely, because the SAP, for whatever reason, tends to be public to the study team, but I do my best to keep it as private as possible.
I was just thinking, as the clinician that comes to all of you with the sample size re-estimation idea, that then you run into problems with the discussions with the funding agency. I'm just thinking, as we're talking about how we approach you and you say, sample size re-estimation is great, but it's not a real clean then request or ask from the funding agency.
Right.
So how have you been? What's your experience been on how to manage that?
Yeah, well, I'll talk about it from my NIDDK experience, so I make sure that I don't give away anything from my NIDS studies. But for my NIDDK experience, so when we build it in, there's always that caveat, right? We're going to present the information to the DSMB. The DSMB is going to make their recommendation to the institute, and then it's up to the institute to figure out what to do.
And do you run into problems with peer review and criticism of at these days with your sample size re-estimation?
I have not.
It's such a minor part of the grant
Yeah.
proposal. Usually it's just a sentence or
And
two.
it's not infrequent that if you look in the history of clinical trials, DSMBs often do that without a quantitative rule. And then the institute still has to deal with it. So it's better to have a prospective quantitative rule. I haven't seen criticism of that, but if it's something that has a pretty high likelihood of going, it's only going to go. And I think what many of the clinical reviewers are going to say is they think what the most likely thing to happen is what the base case is, that the assumptions of the clinical investigators were correct, which we sort of said is probably not true. But so they don't think that blended sample size re-estimation is actually going to trigger. I think when they look at those things, it's nice, but it's nice to. So I don't think we tend to draw a lot of attention to it.
Yeah.
But it's from an inferential perspective, it's a great way to protect against the fact that we get things wrong when we initially specify them.
And I've been in situations where, so we do the sample size re-estimation and it's discussed in closed session. They know an interim analysis coming out, so let's just say the sample size re-estimation says you should increase the sample size because you were really off. The DSMB, thankfully, and the institute said, okay, we know this information, let's keep it private and let's see how the interim analysis goes.
Oh, that's
So
interesting.
no
Yeah,
one
so then it's not a
knows.
blinded sample size re-estimation.
But then they kind of, because it's true, they don't want to alert the study team. I guess they did it that way for this one study. They didn't want to alert the study team to say, hey, you're going to have to increase your sample size. And then the interim analysis, which they don't know the interim analysis yet, but they said, you know what, we know an interim analysis is coming up before we decide about who's going to give the extra money, where's the money going to come from to increase the sample size and all this administrative stuff. Just let's see how things pan out. Because if the study stops, then it doesn't matter, right?
Yeah, if I could avoid doing a sample size re-estimation in any other study, I would definitely try to avoid it, because I think it's such a
It's a
huge logistical
Two questions.
challenge, and, yeah, I mean, just be very conservative about it.
Yeah. But on the other hand, I guess I've seen so many times that the assumptions were wrong. It's kind of like, you want to do it, but you really have to think, like Jordan said, of the logistics. You have to have that conversation with,
And one thing to think about is that it's not, do you remember we did a mock review for PRISMs?
Yeah.
And we had planned a sample size re-estimation, and one of the mock statistical reviewers said, well, what about decreasing the sample size? I was like, what? Why would we ever
Right.
decrease the sample size? But that's, I mean, there's nothing that says it has to go,
Yeah,
it has to
you
go
could
one way.
decrease
So
it.
you have to be prepared to justify if you're only doing it in one direction.
So two questions. In the regular trial, as you said, can we use that previous information, or you were mentioning about whether we give up on the previous information, that data collected to re-estimate the sample size?
So
or-
you wouldn't give up on it, but it's a matter of deciding whether so let's say you design a study with 1,000 patients, and you had planned an interim analysis of 50% of those patients and a sample size re-estimation right about at the same time. If you do the sample size re-estimation, are you still going to do the interim analysis at 500 patients, which was when you said, right, that was 50% of your original sample size, or are you going to bump it back to 50% of the new sample size? Because that's going to change the information that you have available. It's going to change what that boundary looks like. So you have to think about that and what the implications of that decision are, right? Because it is going to change the boundary. It's going to change how big of a difference you need to see.
And I mean, just another logistical issue is the consent forms, which have, this will be a study of 1,400 patients. The central IRBs is actually a lot easier,
Oh,
but like with a multi-site study.
maximum of.
Right, so we're saying like, this patient will have, this study will have,
Or you say approximately, like.
yeah, like, right, like this
some
patient,
range.
right, yeah, like whenever you can be, like,
Yeah.
this patient will have approximately 1,400 to 1,600 patients. Then that saves you from an amendment, anything you can do to prevent amendments.
Because it's possible the institute might not have the money to give you to increase sample size.
Operationally, randomization list, how do you append to the already existing randomization list? If you have stratified with respect to some levels.
We don't do randomization lists. Our randomization schemes are usually centralized, so
Okay.
they log into the system and enter whatever information. So it's dynamically generated, so there's no
Limit.
there's no,
Okay.
But if you had to do it that way, I always recommend making the randomization list much bigger
Yeah.
than you need it.
Yeah, if it's like blocks, you just make a bunch of extra blocks.
Yeah. So, but there is a lot to discuss with the DSMB, because this is all happening with the DSMB, and they're not. So you want to have that conversation before the stuff starts.
Okay, so I think we have maybe 2 minutes.
No, I don't think anybody has any appointments until 11.
Okay.
Like, I'm sure that there's lots of people signed up to talk to you.
Yeah, you're booked.
I had one this morning, only one. I had work to do. So I'm just going to talk about some of
You sign up fake people. Dead people. Oh.
You know how Twitter
I have
has
to
fake
work out
accounts?
So I'm just going to talk about some they're not necessarily, they're sort of statistical issues, but there are also logistical questions that don't necessarily, the investigators don't necessarily come to the table with, and if we take the information that they give us for granted, it's easy to go potentially wrong. So this is an example of a study that we submitted. The study was eventually funded, but it didn't look anything like this when it was funded. But Valerie mentioned yesterday we did a phase 1 study to find the maximum tolerated dose of deferoxamine. And what we found was the maximum tolerated dose was 62 milligrams per kilogram. But the animal data suggested that 32 milligrams per kilogram was effective. And so the investigator wanted to do this selection, essentially, between these two doses. But there was also a question about the time window, and what he wanted to do was to go out to 24 hours, right? Make this study treatment accessible to more people. If we can go out that long, that's great, but we have in our head that time is brain, and so we need to administer study medication as quickly as possible. So he said, I want to look at 2 time windows, 0 to 12, 0 to 24. Okay, the first question that we should ask is, why 12, right? There's absolutely nothing that says that 12 is the right cut point in the 24-hour window. And is it really a cut point? Probably not. There's been some literature in stroke, in ischemic stroke at least, I don't know about hemorrhagic stroke, but that shows that the likelihood of a good outcome decreases pretty continuously over time. So is that 12-hour cut point, is there any data whatsoever to justify that there is this dichotomy? The other question is, how likely are patients to appear in each of these sorts of time windows, right? So when you think about patients coming into the hospital, you might say, yeah, I have an equal chance of somebody coming in within 12 or 24 hours, depending on what type of injury, that might be true. But what I think happens when you give people a time window is that everyone butts up against the end of the time window, right? If you have 24 hours to enroll someone, then study coordinators don't want to come in overnight to do assessments and get them randomized. And sites will tell you that they have 24/7 coverage. So you need to think about what that distribution is going to look like and how is that going to impact your ability to make decisions. So what we hoped, and we are actually, again, what we're doing doesn't look like this anymore. We are still interested in the time window, but what we have is most of our patients, like 2/3 of them, are in the later time window, because even if they come in 2 hours, if they come in 2 hours at 10 o'clock at night, they're sitting until people get there the next morning.
There's a great graph from the European TPA studies for stroke, which had 6-hour windows, and everybody was enrolled between 5 and 6 hours. And it's not necessarily because people are chilling out in Europe, but it's everything that she says. So, and with the time dependence of the brain, you got to be really careful about that in acute studies.
And so not only does it bring into play this question of, okay, well, what can you say about the difference between the time windows when you want to make that decision? But how are you going to translate that to the next study? So if it turns out that we really do need to do it within 0 to 12 hours, but we can only get 1/3 of our patients randomized in that time window, am I going to be able to convince people in the phase 3 you actually have to have someone come in? We're not kidding about that. So you really need to think about what some of these decisions, what the impact of some of them is, both in your current study and long term. And it's a little hard sometimes to get the clinician to think about that, because the primary investigator is invested. He's going to show up when somebody comes in that's a potential patient, right? But at site X, where the study coordinator is shared across 6 different studies, that study coordinator is not going to come in at 2 a.m. So you have to think about these things. Another thing to think about, so I'm moving the arrow, but it's not showing on the screen. So we talked
there, don't you just say I looked at the wrong list, so you're not in a rush.
Oh, thank you.
Yeah.
I have to work on my paper.
It has you with Dan, Nate, John, and Gordon.
Oh.
But then you've got some,
But
yeah,
that's just-
Okay. So I will just point out, so we talked a little bit about sensitivity to things like control rates. So in some disease areas, you have access to previous trials. So we were able actually to do a weighted estimate of some control arms from previous studies in this to come up with our control rate. And again, luckily, we're in that middle place where it doesn't too much matter. But if you have, we've talked in our small group about constructing a confidence interval around that estimate and using one of the bounds of the confidence interval to give yourself some wiggle room. It's often the case, I think, that the investigators have access to this information. They may not necessarily be forthcoming until you sort of try to pull it out of them. And you might, I know we're all busy, but one of the things that came up in the phase 1 study when you're talking about dosing and what are the right rates and things like that, try to really dig into the literature and understand where the information that they're giving you is coming from. So if they're giving you, saying we want to target a dose-limiting toxicity rate of 40%, understand where that information came from. In our case, the initial estimate that we thought we were shooting for was serious adverse events in an untreated population. There was no wiggle room in that. So if you're trying to say, I'm going to give a medical therapy and I'm going to have no increase whatsoever in the serious adverse event rate for this patient population, it's not giving the intervention a whole lot of room to do anything, right? You need to give at least enough to make it active. And there's likely to be some increase that's associated with that. So you really need to try to dig into the literature and not just take what the investigator has sort of at face value. Not that they're ever misleading, but they may not understand that we don't know, right?
And we may be winging it more than we should be.
And more than you share, yeah.
Well, as a species, we are conditioned towards overconfidence and certainty. Patients prefer for us to not say, you know what, you might have anything. I can't really tell.
Right.
But sometimes that's all we know, but we are conditioned in terms of grant submissions, how we approach patients, to overemphasize our certainties. That's one thing you can put into your priors about what clinicians are telling you. They are overconfident and underestimating the real uncertainty of what they're doing.
Doubt.
I think when the time it takes to do all of this, I think that's the other thing that I struggle with a lot too, is that, it's like, oh, it's due next week, and you're like, I haven't